For today's presentation, my colleague, Melissa Castora-Binkley, PQA Senior Director of Research, would like to provide an update on our important work to advance the quality of oral anti-cancer medication use. Melissa?
Thanks so much, Carolyn. PQA has a new report that details priorities for improving the quality of care for individuals on oral anti-cancer medications. We convened 23 national experts and patients, and their number one priority for measurement is a health plan performance measure to assess the degree to which patients take oral anti-cancer medications as prescribed. Informed by this guidance, PQA will begin research next year to advance a health plan measure concept for adherence or persistence to oral anti-cancer medications. This prioritization process was informed by an expansive environmental scan that we conducted to identify quality gaps and to identify existing measures relevant to oral anti-cancer medication use. Not surprisingly, we found a lack of relevant oral anti-cancer medication-related quality measures for health plan and pharmacy performance measurement. The complexity of cancer treatment presents unique challenges to the development of feasible quality measures. But we are eager to pursue research that can advance measure concepts that support high-quality care and improved patient outcomes. Visit our website to access the full report, and a link has been shared in the chat here. We welcome your feedback, and we invite you to support us as we move forward with this very important work. Thanks so much. Back to you, Carolyn.
Thanks, Melissa. So as we begin our presentation, I'd like to take a few minutes just to introduce you to our speakers today. My name is Carolyn Lockwood. I'm the Director of Performance Measurement at PQA, and joining me today from PQA also is my colleague, Razanne Oueini, who is the Senior Manager Performance Measurement. We're also very excited today to have some special guests from Kaiser Permanente, Dr. Daniel Powers and Dr. Eric Anthony Tony Lee. Dr. Lee and Dr. Powers will be discussing the approach that Kaiser has taken to reduce polypharmacy in older adults. Dr. Powers, a pharmacist, is Director of Drug Use Management at Kaiser Permanente, where he's responsible for coordinating affordability and quality initiatives for multiple KP regions. Dr. Lee is a primary care physician at Kaiser Permanente West LA. For the past 14 years, he's been the physician lead/co-lead for KP Southern California's effort to reduce the use of high-risk medication in older adults. Dr. Lee's efforts were recognized in 2017 when he was named the Choosing Wisely Champion by the American Geriatric Society. In addition to conducting over 34 hours of direct patient care per week at his office, he continues to write about improving medication safety in peer-reviewed journals, most recently on the reduction of poly-CNS medication regimens within KP Southern California from 2018 to 2020. So for today's presentation, we're just going to briefly review the PQA measure development and maintenance process. We're going to discuss the way PQA measures assist in improving medication safety in older adults. And finally, Kaiser Permanente will provide a case study on their approach to polypharmacy in the older adults. So before we begin the presentation, I just want to take a brief moment just to review how PQA develops and maintains our quality measures. Lots of effort and various expertise is needed to not only developing a measure, but also in maintaining it. During each phase of the process, PQA not only relies on our internal expertise, but also the expertise of various stakeholders. For example, in the measure conceptualization phase, we review all concepts with stakeholders such as our MCAG or Measure Concept Advisory Group to assist in prioritizing those proposed concepts. During specification, this is where the specifications are developed and an understanding of what is feasible to collect as the data that is required. We rely on our technical expert panel or our TEP. This is a group of stakeholders that is comprised of individuals with expertise related to the measure topic, and that they provide input on the development of the specifications and data requirements. The testing phase is where we evaluate the measure specs and value sets to determine if logic developed is producing reliable and valid results. Results of this testing are reviewed by the performance measurement team, and the results are additionally reviewed and evaluated by our quality measure expert panel, or QMEP. Once a measure has been specified and found to be valid and reliable, it is then presented to our PQA members for endorsement voting. Measures that have been endorsed are reviewed to ensure that they remain current and relevant as specified. Or do we need to revise and potentially retest that measure? One thing to keep in mind is that even though this is presented usually in a linear fashion, depending upon updates or revisions that may need to be made to a measure, we may need to retest this particular measure to ensure that it remains reliable and valid. In that case, PQA reviews the evidence and potential considerations and develops a proposed recommendation and will present to our measure update panel for review and input. If the revisions are approved by greater than 60% of the MUP, the recommendations could go one of two ways. They could go straight for QMEP for review and input, or if the revisions had the potential to impact how a measure is calculated, it would then need to be retested to ensure that it remains reliable and valid, and those results would then be presented to our quality metrics expert panel for review. Each measure, whether it is being developed or is under review due to updated evidence, is evaluated using the same criteria. The criteria are listed here on this slide. Importance: is the measure focused on a priority area? Is it evidence-based? And does it have a positive impact? Scientific acceptability: does it produce consistent and credible results? Feasibility: are the data needed to calculate the measure readily available? And last but not least is usability. Is there an opportunity for implementation of this measure? Can the results be used for both accountability and performance improvement? As we know, ensuring medication safety is a priority area, especially medication safety in the older adults. Polypharmacy, or the use of multiple drugs to treat diseases and other conditions, is a high priority, lots of evidence support, and if addressed, can definitely have a positive impact. At this time, I'm going to pass it to my colleague Razanne to discuss the impact of polypharmacy in the older adult, what drives it, and the specific PQA measures that can help efforts to decrease medication overload in the adult population. Razanne?
Thanks so much, Carolyn. And I'm really glad that we're going to be able to spend some time today discussing a topic that is really critically important within healthcare, and one that, for me as a pharmacist, really dear to my heart. So diving in here to the concept of polypharmacy, it's really a concept that is variably defined in the scientific literature and in practice. We see these varying thresholds that are used in terms of the number of medications that correspond to a patient having polypharmacy, the types of different medications required. But overall, we really are especially concerned with this overuse of medications in older adults. So this is a concern for a number of reasons, starting with, when we age, there are a lot of changes that occur to our bodies. And a major one of those changes is related to pharmacokinetics, meaning the way that our bodies absorb, distribute, metabolize, and excrete drugs. And as we age, this process is altered. So what this ultimately leads to are different risks associated with unsafe medication use in this population, including increased falls and fractures. We see CNS effects like cognitive impairment, delirium, dementia, and altered mental status, as well as anticholinergic effects, which can have all sorts of effects on the, many different systems within our bodies, including the GI system, cardiovascular, genitourinary, musculoskeletal systems, patients' vision, just to name a few, as well as CNS effects like impaired memory. And further, we just really want to avoid the ultimate increases in hospitalizations and mortality that can result from this unsafe medication use within this population. So some statistics listed here reported by the Loan Institute show that 42% of older adults take 5 or more prescription medications, while nearly 20% are taking 10 or more. And in addition to the, of course, improved health outcomes that can come from reducing this unnecessary medication use, they also report that it could save up to $62 billion in hospitalizations over 10 years by also reducing this type of dangerous medication use. Now, how do we get to these situations where patients are really overloaded with medications, and why is it seemingly so common given those statistics we just described? So again here, the Loan Institute reports these three main drivers listed here on the slide, and our presenters from Kaiser will actually touch on how they've addressed some of these issues within their own practice setting here in a few minutes, so we'll stay tuned for that. But starting here with a culture of prescribing, and it's especially related to the increased use of medications that we see throughout the normal aging process, and often that desire from both providers and patients to be able to do something for every problem that arises in a patient's medical care. We also know that there are gaps in information and knowledge to be able to appraise evidence and be able to make informed decisions about medications. And lastly, a pervasive issue, which is the fragmentation of care that really often occurs in our healthcare system, with a lack of communication that often occurs between all of a patient's providers, whether that includes multiple specialists in addition to a patient's primary care provider. And this can often lead to prescribing medications for what may appear to be a new condition for a patient, but in actuality may be an adverse effect from another medication that had been prescribed earlier, leading to what we call a prescribing cascade. So overall, as you can see, these various factors working together can ultimately lead to a patient just really being put on too many medications, or maybe an inappropriate number of medications. So here at PQA, a lot of resources have been devoted to developing performance measures that address medication safety in older adults. So I'll walk through here a bit of a timeline of the different measures that have been developed and how they've been used. So the first of these measures, starting here on the left-hand side, was use of high-risk medications in the elderly, also known as HRM. And this was PQA endorsed back in 2008. And this measure captured the percentage of individuals 65 or older, so that older adult population that we're interested in, who had received 2 or more prescription claims for a high-risk medication within a given measurement year. And this measure was based on the Beers criteria, which, if you're not familiar, is a list that's published by the American Geriatric Society. And it's a list of potentially inappropriate medications that are best avoided in older adults due to their association with poor health outcomes. And this measure was used within the CMS Part D program on the display page from 2011 up until its retirement in 2021. Now, within those intervening years, PQA developed 2 new polypharmacy measures, those being Poly-ACH and Poly-CNS, and those stand for Polypharmacy, use of multiple anticholinergic medications in older adults, and relatedly, Polypharmacy, use of multiple CNS active medications in older adults. And those both received PQA endorsement in 2017. So these measures focus on a subset of the guidelines related to drug-drug interactions within specific therapeutic categories. As you can see, they're a bit more tailored to specific therapeutic areas. And so with the retirement of HRM, PQA, I believe that stakeholders will be able to then focus resources on these newer medication safety measures that may have had a greater impact or greater opportunity for meaningful impact. And we'll get into the specifics of what exactly these measures capture in just a moment here. But after their endorsement in 2017, they were also implemented into the Part D program, firstly being added to the patient safety report in 2018, and subsequently moving to the display page in 2021. And actually, the most recent development with these 2 measures is that in CMS's most recent proposed rule, which was released at the end of 2022, it is CMS 4201P, that proposed rule. They proposed the addition of these 2 measures to the 2026 Part D star ratings. This particular proposal has not yet been finalized, however, but we eagerly await additional news on that front. But now we'll go ahead and dive into the specifics of the 2 polypharmacy measures that I mentioned, beginning here with Poly-ACH. So this measure is also in alignment with the AGS Beers criteria, which provides a strong recommendation based on moderate evidence that older adults should avoid concurrent use of 2 or more anticholinergic medications due to serious adverse effects being reported within this population. Now, we know that even the use of just one or more of these medications with anticholinergic properties increases the risk of cognitive decline, which can even occur from short-term use of these agents, along with delirium and falls and fractures. And this particular interaction is noted within Table 5 of the Beers criteria, with the specific medications listed in Table 7, if you wanted to cross-reference any of these with the Beers criteria themselves. So really the intent of this measure is to reduce that concurrent use of the 2 or more anticholinergic meds. And as we've said, this combination really poses serious safety concerns within the older adult population, and ultimately reducing this prescription use should result in better patient outcomes and quality of life. Now, for reference, what's displayed here on the slide for you is the current medication list for poly-ACH, taken from PQA's measure manual. And this is aligned with the 2019 release of the Beers criteria. There has since been an update to the criteria released just this year in 2023, which removed 14 of these medications from Table 7, so the table where this list came from. And that was due to those medications having low use or not being available in the US market. So beginning actually with the 2024 PQA measure manual, this table will look a little different as we refine it to align with the updated Beers criteria. So moving on to the related measure here, poly-CNS. So similarly, this measure's rationale comes from the Beers criteria, which we've mentioned a few times now, which recommends avoiding concurrent use of 3 or more CNS active agents in older adults. And this is specifically due to an increased risk of falls, and for some combinations of these medications, also an increased risk of fractures. Similarly, this combination is noted in Table 5 of the Beers criteria. And ultimately, this measure intends to reduce those combinations of CNS active meds to ultimately try to reduce these incidents of fractures, falls, and recurrent falls, which should lead to fewer hospitalizations and increased quality of life for these patients. Again, for reference, here is the medication table as currently specified for poly-CNS in PQA's measure manual. This table is also in the process of being refined to align with the most recent Beers criteria, where an additional class of medications was added, those being several skeletal muscle relaxants. So PQA will actually begin testing this fall to assess how those additional medications affect measure rates. And those results will be reviewed by PQA's quality metrics expert panel. And if those changes are approved, this change is anticipated to occur for the 2025 measure manual release. So this time I am very excited to introduce our speakers from Kaiser Permanente, Southern California, Dr. Tony Lee and Dan Powers, who have led some amazing work in their institution to address polypharmacy in their older adult population. So without further ado, I will hand it over to Dan to share about the great work being done at Kaiser.
Thank you, Razanne. Yeah, I'm very glad and very proud to be here today on behalf of Kaiser Permanente and the work that we do around polypharmacy. So with our next slide, talk about why do we care about polypharmacy? Well, from our perspective, obviously there's health issues, there's hospitalization issues, there's cost issues, but it's an idea around unifying the approach to geriatric syndromes, things that are predominant or often associated with aging, such as falls, dementia, delirium, incontinence, these sort of things. And frailty is an increased vulnerability to these insults due to reduced reserve capacity with aging, as Razanne mentioned. And preventing these things can go a long way to improving the quality of life for these members. If you can address one risk factor, you can probably affect many of these syndromes. And that's why we talk about polypharmacy. The use of high-risk medications, as was just outlined, are classic risk factors for geriatric syndromes. And disability is often associated with these syndromes. Of course, disability can lead to increased morbidity, mortality, and certainly cost of care. We like to maintain the physical and mental function of our members, our older adults, by focusing on the prevention of these geriatric syndromes. So a couple of studies that talk a little bit about this in the literature there in the lower right-hand corner. In the first study, a population-based survey of about 2,000 patients age 65 and older, asking them, would you want to decrease the amount of meds you take? 92% said they'd like to stop at least one medication if the physician said was possible. And I want to point out that line. As a pharmacist, we often know that, we can often say a lot to our patients, but they'll always ask, well, what did my physician think about it? What did the physician think I should do? And so we really want to emphasize that collegial environment where both the physician and the pharmacist are on the same page, the physician having that discussion with the patient will be more effective in getting that change made. And about 2/3 of them wish they could stop some number of medications that they're taking. If you look at the two studies outlined below, we have a study in patients post-discharge going to a post-acute facility where there was an intervention made to stop these medications where possible. The intervention group had 14% fewer medications upon discharge from the post-acute facility, and the intervention group had also 15% fewer medications than 90 days later. So there are no adverse effects in this group, which shows you that it can be done safely. A lot of these meds just aren't as necessary as they perhaps once were, and are candidates for deprescribing. In the second study, we got 70 patients, age 83, in community dwelling frail patients. 311 medications were stopped in 64 of these patients, an average of about 4.5 medications per member. 2% had to restart these medications. I mean, it's kind of like a drug holiday. In some cases, these medications will have to be restarted, but as you can see, very, very few of them that occurs. This discontinuation was successful in about 80% of these patients. And the best part about this is that 88% of them reported feeling better with fewer medications. And so I think that's really the take-home message. I mean, it's difficult for them to take a lot of these medications. There's a lot of, potential drug interactions. There's all sorts of adverse effects associated with medications. There's a certain out-of-pocket difficulty for many of them. So reducing those medications can help them in many ways, not the least of which is to make them feel better. If we can go to the next slide. All right, so this is where I'd like to talk a little bit about our team and what we do at Kaiser Permanente. So consensus building, I think Dr. Lee will speak about this in the future. Getting people on the same page that this is a problem. We're very focused on prescribing. We also should be pretty focused on deprescribing where it's not necessary. So getting the different departments together, the high utilizers, the treating physicians for our older individuals is really important. Next thing at our organization is that pharmacist and physician work together. There's this secret sauce, this collaboration between the two groups of healthcare professionals, trying to come to a consensus about how to treat and how to set up the framework and the algorithms to get this work done. Controlling, or I should say, disseminating the information, that's where our department comes in. So we're gathering the information about members who are on multiple medications, as you heard earlier, 5 or more medications for polypharmacy, 10 or more perhaps for hyperpolypharmacy. Getting those lists of patients out, the drugs that they're on, perhaps identifying the high-risk drugs that they may consider for discontinuation that may not have an apparent need in their med list or their problem list. And then, as Dr. Lee will talk about specifically shortly, these case-based presentations where we can talk about what's the process, how do you go about doing this? It's not easy. I mean, it's one of the things when we first introduced these metrics based on the PQA work about 5 years ago. We're told this isn't going to be easy. This is pretty tough work. You got to get a lot of different specialties involved. It's going to take time. There's got to be follow-up. Yes, but the journey of 1,000 miles begins with a single step. You have to start this work in order to get through it. And I'm proud to say that over those 5 years, we've done pretty well in moving our patients off these medications in poly-CNS, poly-ACH, and an overarching hyperpolypharmacy metric that we also have. We go to the next slide. So let's talk a little bit about the questions that we're facing. So the discussions on the need of medications, focuses on quality. Our MedTech work, our Medication Treatment Appropriateness Committee is focused on quality. Are medications needed? Do these medications improve the function or preserve the function that the member is interested in? What are the risks and benefits of being on these medications? And no medication is totally benign. That's why they're prescriptions. Whether those be new start medications or refill medications, basically increasing the length of time patients are on therapy or starting new therapies. Are there safer alternatives? And this is something we have to think about too. Many other modalities besides medications can be used to assist these patients with their conditions. What are the patient's goals? What can be achieved with the medication? And what does the patient believe that they need to be on this medication? And to answer these questions, I'd like to turn over the discussion to my colleague, Dr. Lee.
Great. Great, thank you, Dan. So I just want to present a few case examples for patients I've seen as a primary care physician over the past 24 years, and just ways in which conversations I've had with patients in trying to stop these medications. So case number one, 68-year-old man with tingling and numbness at the bottom of the feet for the past year, but actually has no pain. Past medical history is prediabetes, hypertension, asthma. The patient's on some blood pressure medications and some asthma medications. The examination shows that he's a reasonably robust older adult. His mental status exam, he has an Ottawa 3DY, which is normal. The Ottawa 3DY is kind of a quick memory screen that's more validated in the emergency room setting. He walks well. Again, a sign that perhaps the patient's more robust. His sensation is intact to light touch bilaterally, and his pulses of his feet are normal bilaterally as well. So my assessment was, after looking at his labs as well, peripheral neuropathy. And so oftentimes when patients see me, they sometimes want to have a quick fix. They want to, they're also concerned as far as what's going on. And so in this patient, as I do for most patients with peripheral neuropathy and no warning signs, is I did not prescribe many medications. I discussed with the patient common medications that are frequently prescribed, off-label by the way, which might include tricyclic antidepressants, gabapentin, duloxetine. But the TCAs and gabapentin, especially from my experience, is really associated with cognitive loss, poor balance, falls, and fractures, and that the tingling in his feet without pain is really not the best indication to be on such medications. Something I think sometimes patients want to know is that the neuropathy is not an indication that it's going to change the course of whatever disease that they have. It's not like being on a blood pressure medicine. It's not like being on a statin, where you need to be on a statin to reduce your future risk of CVD. And I think a lot of patients are comforted when I tell them that if they whether they take the neuropathy medication for neuropathy or don't take medication for neuropathy, it's not going to change the course of their problem. And that, in fact, the best way to treat neuropathy due to prediabetes or diabetes is just lowering the sugar to reduce their A1C. And so oftentimes when physicians, including myself, see patients, we have some kind of implicit bias that perhaps they're here to see me because they want a pill, they want a medication, which is just absolutely not true. In fact, what they often want, or what they usually want, is just a thoughtful conversation with their primary care physician or with their specialist physician about the problem, the course of action, and that they don't always want to be on medication. And so for this patient, it's especially easy for me because I've been his doc for years and he trusted me. Next slide. So case number two, it's a 67-year-old woman who I saw for the annual wellness visit for Medicare. It's actually a patient I've known for decades, at least 10 years, perhaps almost 20 years. And she had a history of an incidental ulcer in 2017, where she had an upper endoscopy that was indicated for GERD and dysphagia, and a history of hypertension, hyperlipidemia, GERD, and hypothyroidism, just on a bunch of blood pressure medicines, cholesterol medicines, thyroid, and also famotidine. And when I looked at the famotidine, when I was reconciling her medications, I realized she hadn't picked up the famotidine for almost 1 year. And on review of systems, she didn't have any significant GERD, no dysphagia after she improved her diet. In fact, she told me that she stopped her famotidine last year since she no longer had GERD. And she actually recalled my conversation that when I looked at the notes, I first documented in 2017 to use Tums PRN and in my regular reminders, just querying its continued need. So on exam, again, she was a robust woman, fully independent, functional, normal cognitive status. And so just thoughts with this was that in many ways I was really excited when she told me she stopped it by herself. And it's just a reminder to me that sometimes it just takes years of discussion for a primary care physician to the patient, just to eventually convince the patient to deprescribe. Famotidine increases, famotidine is obviously not the worst of medications, but it is actually looked at in the Beers criteria. Famotidine increases risk of mental status changes in patients with creatinine clearance of under 50, and it's also contraindicated in patients with delirium. So anyways, next slide. Patient case number 3. This is a 67-year-old woman with an A1C of 5.7, and I was the covering physician for a colleague. My colleague was on vacation, and so I was covering as in-basket. And so medications was semaglutide. She was on insulin 16 units twice a day, and then she was on metformin and atorvastatin. And so when I saw this A1C of 5.7, I just took a look at it. As usual, I take a look at the medications that she was on and realized that she was on 3 diabetic medications. And so I reduced her insulin from 16 units twice a day to 10 units twice a day, and asked her to recheck an A1C in a month. And so 5 weeks later, her A1C was 5.9 on 10 units twice a day. So from there, I reduced her insulin to 5 units twice a day. And 6 weeks later, her A1C was 6.7. And so I reduced her insulin to 3 units twice a day while encouraging her to optimize her lifestyle. And I let her know that potentially we could actually stop her insulin with a repeat A1C in 6 weeks. And I haven't had the lab follow-up since then, but she's kind of on the right track of potentially completely deprescribing insulin. And so in an article from the New England Journal of Medicine, I think probably 15 years ago now, Budnitz of the CDC demonstrated that insulin is the second most likely medication that would lead an older adult to be hospitalized for an adverse drug event. And in fact, the American Geriatric Society, as well as our Southern California Kaiser guidelines, states that for older adults, an A1C of greater than 7.0 to 7.9 is preferred to minimize the risk of hypoglycemia and other untoward outcomes. And so hypoglycemia medication should be reduced for an A1C of less than 7 unless the patient is only on monotherapy, metformin as monotherapy. Next slide. So this is a 78-year-old patient with spinal stenosis. Medications are pregabalin, duloxetine, insulin, amlodipine, lisinopril, atorvastatin, finasteride, and metformin. And when I saw him, and he too was one of my primary care patients, when I asked him whether or not the pregabalin, which was prescribed by the back specialist, whether or not the pregabalin was helpful or not. And he admitted he wasn't actually sure whether it helped. I actually find that this is a pretty common comment for my patients who are prescribed medications, kind of for symptomatic low level, for symptomatic pain problems, that they are not always sure whether or not the medication that was prescribed to them actually helps or not. And so, and this includes my own patients or patients I meet at urgent care for the very first time. And so for this patient, a patient of mine, I advised him to taper his pregabalin from TID to BID to QD, and then stop it. And I made a follow-up appointment for him to see me 2 months later. And 2 months later, he was no longer on pregabalin, and his pain was unchanged. And for my patients, they have a way of being able to email me directly through their electronic medical record. And so if he had had pain that worsened, it would be, and especially affecting the person's function, it would be reasonable to at least consider continuation of these medications. But when I talk to these patients about whether or not they're helpful or whether or not they want to be on the medications, I always talk to them about how, from a global picture, from an overall standpoint, potentially whether or not being on such a medication could actually worsen their overall global function, their overall independence in performing their activities of daily living. And so sometimes patients are willing to be on medications. Patients are willing to accept that medications do not always help for pain symptoms. And so some patients are just willing to live with the pain as long as it's a low level pain, with the knowledge that that it's not going to potentially impair their ADLs, that it won't potentially increase the risk for hip fractures, for example. Next slide. So this patient is an 80-year-old woman with urinary incontinence, past medical history of hypertension, diabetes, and also a history of hip fracture, on some standard medications, amlodipine, metformin, atorvastatin, alendronate, calcium, and she's on oxybutynin twice a day around the clock. And so for this patient, she rarely goes outside home because she has functional limitations. And for her, my assessment was that she was at high risk for future falls and fractures, because one of the most important risk factors for future falls is a history of falls. One of the most important risk factors for a future fracture is a history of fracture. And because she rarely goes out at home, because she perhaps suffers from social isolation, because she's an older woman, she's 80 years old, she's also at risk for, at a high risk for having future cognitive impairment as well, if she doesn't already have cognitive impairment. And so for this patient, I just let her know that this oxybutynin is something that could potentially put your independence at risk. And so I advised her to stop the oxybutynin. I advised her to do time toileting, to do some Kegel exercises. I told her that she could consider using pads when she went out instead, if it was not so bad. And also, and something which I didn't put in the slides, is that for her, physical therapy would be indicated as well, because physical therapy is something that can help incontinence as a non-pharmacologic treatment too. Next slide. So anyways, we have a growing population of older adults, and I've always felt that we need to change the paradigm in which we treat our older adult patients. And so I really want to thank PQA for developing these polypharmacy metrics, because it really forces physicians to really question whether or not this additional medication is needed for our patients at risk for frailty. Physicians are really skilled at prescribing medications, but I think we need to have a better understanding as far as how to deprescribe medications. For example, I think many physicians don't quite realize that when a person's on an SSRI, they're a little bit higher risk for an SSRI discontinuation syndrome. So a tapering program would be needed. And if you look at the literature, there's not much literature as far as how to deprescribe SSRIs in a very pragmatic way in a busy primary care practice. Older adults just tend to accumulate medications. And so active management is needed to prevent polypharmacy and hyperpolypharmacy. And so this really comes down to, we need to do a good job. We need to do a better job in reconciling our medications. And we need to take the time to ask our patients whether or not they still need the medications. Do those indications still exist? Was the medicine helpful in the first place? Did the treatment course of that drug finish? Or perhaps has a patient gotten older to the point where this medication might then become a higher risk medication in older adults that the person previously wasn't 10 years ago? There needs to be discussions and agreements made among physicians of all specialties and pharmacy experts throughout an organization for successful population-wide reductions in medications, but particularly in older adult patients. There needs to be a reduction in unnecessary medications. Reduction in unnecessary medication use will result in improved quality. There will be fewer drug disease, drug age-related adverse events. There will be better adherence to more critical medications, because every time you are on the extra gabapentin or lorazepam, it's going to kind of prevent a person from remembering or perhaps having the money, or if they have financial barriers to get the refills of their statins or buy their medications for blood pressures, especially, for example, in patients with a stroke or heart attack. And in the end, it'll be less burden for the patients as well, the need to take so many medications in one day. Reduction in unnecessary medications will reduce costs. Resources are often reoriented to quality improvements. These resources can be reoriented for quality improvements for other programs. And we need to remember that up to 15% of all hospital admissions in older patients and patients over this age of 65 are due to an adverse drug event. And so if we can avoid these preventable hospitalizations, the patient as well as the organization can win. And so what we've actually demonstrated during the time that we've had a chance to address the polypharmacy and the polypharmacy PQA measures is that we can reduce concurrent use of polypharmacy. However, it takes time, it takes effort, and it takes focus. And so, so Dan, for the last slide.
Certainly, Dr. Lee. I really enjoy working with you over the many years that we've been collaborative on this topic. It is a challenge, but this work across our organization and the 8 regions that we have is very large. So it takes a village, it takes a large team. So I'll want to say thank you to the folks that have contributed to it, particularly Dr. Benjamin Broder. He is our regional area medical, our regional area medical director for clinical and quality analysis, who co-chairs the MedTech group with us. And my team, Steve Chang, William Liu, and Monica Yoshinaga, and our colleague in Med Group Assistance, Dr. Steven Steinberg, and of course, Dr. Lee. Linda Guzman is our National Pharmacy Quality Director, who helped organize our presentation today, and as well as a countless number of physician champions, drug education coordinators, clinical pharmacists, nurses, you name it, that are involved with this work across several million members in our organization. So thank you to all of them, and very glad to be here today to present to you our work.
Thank you, Dr. Lee and Daniel. Greatly appreciate this and providing input and how KP has done such great work. We're going to open it up now. If there are any questions and answers for either the PQA team or the Kaiser Permanente team, please feel free to drop those in to the Q&A feature. And one of us will help answer the question. So we'll give folks a couple of seconds to see if we have any questions. Razanne, I think this might be one for you. We have a question that's been dropped in that says, you had mentioned that the poly measures potentially going into the STARS rating. Do you have any additional information on that?
Yeah, good question here about will the poly measures be moved into the STAR ratings? And of course, PQA cannot speak on behalf of CMS. That is ultimately within their purview to move forward through their process to add it officially to the STAR ratings. As far as we know, it has just been proposed, as I mentioned earlier, in that most recent proposed rule at the end of 2022. However, in their most recent final rule, it was not yet finalized. So because of that delay, we would not anticipate that it would move into the STAR ratings in 2026. So we would potentially anticipate it being effective at the soonest in 2027 for the STAR ratings. But again, like I said, we can't speak for CMS specifically, so we would advise reaching out to them directly for more information there.
Thanks, Razanne. Dr. Lee, we have a question for you. When you were giving one of your patient scenarios, you noted a questioning of the patient's need for pregabalin. I hope I said that correctly, so I'm not a pharmacist, so pardon me if I mispronounced that. They wanted to know what prompted you to question the patient's need for pregabalin.
So I, as a clinician, I tend to ask all my patients about medications that are usually considered potentially high-risk medications and whether they work or they don't work. And so pregabalin, which is Lyrica, is a classic medication that that is high risk. It potentially increases dizziness, somnolence, confusion. And so it's a medication that that the literature has questioned whether or not it's an appropriate medication for pain. And it's off-label too. It's actually originally designed, I think, for seizures too. It's related to gabapentin.
We have another question for the KP team. Have you found that either member or provider engagement to be more successful in bringing awareness and deprescribing?
I'm sorry, can you ask the question again?
Sure. They wanted to know, have you found that either member or provider engagement to be more successful as you're bringing awareness to polypharmacy and deprescribing?
So in clinic, we certainly have some patients who ask about whether or not they need to be on medications or not. This is pretty frequent actually for blood pressure medications, for statins, for example, and with stroke being one of the leading causes of disability in older adults, we usually think that the use of blood pressure medications or statins are important, unless obviously the blood pressure goes too low on blood pressure medications. So we do get queries about those. We don't actually, from my perspective, I don't get that many queries as far as whether or not medications that patients perceive they need it for, they're being used for neuropathic reasons. I don't actually get too many questions about whether they should be using them or not, or whether they can stop them or not. It usually comes from me, and perhaps it's from my perspective, kind of leading, being one of the physician champions for this kind of concern. But the fact that these medications, the fact that these medications are prescribed so frequently, again, they tend to accumulate, suggests that perhaps members are not asking enough, and perhaps it suggests that physicians are not asking enough as well about whether or not they should continue to use them.
I can chime in a little bit on that too, if you'd like. It's one of the reasons why we our active efforts to, physicians are very busy. Patients often come in focused with a specific, ailment that they want to have addressed. So the work that we do brings together the list of patients, the drugs that they're on, potential risky combinations, to educate the physicians and help them in their conversations with these members. We also have a lot of clinical pharmacy teams that interact with patients, and this is also part of the work that they do to attack it on multiple fronts. And sometimes it takes a combined message to get the work done.
Thank you. So Dr. Lee, I think this one's probably going to come to you. For the patient you discussed on insulin, isn't increased A1C a poor outcome as well?
Yeah. So yeah, when you look at the American Geriatric Society's recommendations for goal A1Cs, it is between 7. It's the AGS recommends that medications be initiated with an A1C of 7.5 or higher. So that's kind of their starting point for it. And so the bigger concern is not hyperglycemia in older adults with diabetes. The bigger concern is hypoglycemia in older adults with diabetes. And so in fact, as I mentioned, the second most common cause for the most common cause for an older adult to go to the emergency room, which leads to a hospitalization. The second most likely the second most likely medication that would lead an older adult to be hospitalized via the emergency room is insulin. And these sulfonylureas are also one of these really high-risk medications that lead older adults to the hospital as well. So because the time frame in which the complication of diabetes can affect a patient's outcomes is in the range of decades, having a really strict control of A1C is not necessary. And that was also shown in the Accord study, as well as the Advanced study, perhaps that was published in the New England Journal of Medicine roughly 20 years ago.
All right, thank you. We have time for probably one more. Let's see, we've got one coming in. This is going to go back to Dan, you and Dr. Lee. Can you provide any suggestions for solving issues related to deprescribing with EMR systems and pharmacies relying on e-prescribing for getting medication orders?
Carolyn, can you just say that question once more, please?
Sure. Can you provide any suggestions for solving issues related to deprescribing within electronic medical record systems and pharmacies that are relying on e-prescribing for getting medication orders?
Yeah, I mean that's a really good question, because what happens is from a clinician standpoint, from a primary care physician standpoint, is I probably get about 20 requests for refills per day. And unfortunately, that takes a lot of time. I mean, if it just took 1 second refill each medication, that's, it wouldn't take any time. But, when you get medications and you need to figure out when the last K was, last creatinine was, when you need to find out when the last blood pressure was done, et cetera, when the last TSH was done for a thyroid refill, it can be pretty burdensome. So, so sometimes the EMR actually makes it, it probably allows for more of this polypharmacy to occur, because again, it potentially can eat up so much time to refill medications. From my end, when I do see a high-risk medication that's prescribed for older adults, I do take the time to send a message to my nurse saying, asking those same questions. Does that patient still need to be on the medication? Is it helpful? Would the patient be willing to stop the medication slowly if he understands that that's a potentially high-risk medication? And just to kind of make a comment, the reason why it comes to me is that if it's prescribed, if this quote high-risk medication is prescribed by the urgent care, if this high-risk medication was prescribed by the specialist, it often winds up coming back to the PCP. So I'm not sure what the best way is from an EMR standpoint, but again, I think one of the beauties in which we have within Kaiser Permanente, having this MedTech group that Dan leads, allows us to centrally know when a person's on high-risk medications.
Great, thank you. All right, so we are at the end. So I'd like to take a moment, Dan and Dr. Lee, to thank you and the Kaiser team for working with us diligently on this and assisting us in providing this very important webinar today for not only our members, but also very informative for our team as well. So thank you both. And thank you to Kaiser Permanente for all of their hard work.
Great.
So as we wrap up, just a couple of announcements. We have several things that are coming very quickly. Just as a reminder, we have our Leadership Summit. That is planned for November 2nd through the 3rd in Arlington. The registration link has been provided directly to the key contact that we have. So any questions that you may have about the PQA Leadership Summit, you can reach out to meetings@pqaalliance.org. We also have our PQA Convenes. This is being conducted directly preceding our Leadership Summit. It is on advancing medication therapy quality measurement. As the summit, we also, the key contact for your organization also has the registration information. And PQA members receive a registration discount for this event. Again, any questions about our PQA convenes, please reach out to meetings@pqaalliance.org. Additionally, SAM, our stakeholder advisory meeting, saved the date. Our next one for Q4 is coming up on October 25th from 1 to 1:45 p.m. Eastern Time. Additionally, last but not least, our next quality forum is Diverse Voices in Quality, that is sponsored by PerformRx. That will occur on Thursday, October 12th from 1 to 2. And yes, slides and recordings will be in the membership library. The recording will be on YouTube, and the slides will be in our membership resource library, probably within a week of the conclusion of this presentation. Again, thank you to PQA Performance Measurement Team and to KP for the presentation today. Thank you and have a great afternoon.